Welcome to Gender Queries, a podcast about trans and gender diverse healthcare in Atlantic Canada. I'm AJ and I use he, they pronouns.
I'm Jess and I use they, she pronouns.
I'm Sam and I use they, them pronouns.
Today we're going to talk about gendered healthcare. Healthcare can be gendered in a lot of ways. A lot of what we're going to talk about today comes down to the fact that trans people need access to healthcare that's specific to the anatomy that they have. And a lot of these spaces are not very welcoming to trans people. And that can be because of the space itself, because of the interactions that someone has in those spaces, or it can just be the fact that the person has to go and get healthcare for a part of their body that might give them dysphoria. People can also experience discrimination in these spaces, and all of this can interfere with someone's ability to access care or lead to avoidance. And in the end, we see poorer health outcomes as a consequence. So when I say gendered healthcare, what types of healthcare pop into your head?
I mean, all of OBGYN, which I get into later on the show.
One thing that I think about is how providers might perceive an individual based on the gender marker on their chart. They may automatically make assumptions about what that means for that person's internal anatomy, and that comes from the binary that exists within the system that they work, and not necessarily
not as a reflection of their values.
Yeah. And then we have, in healthcare too, far too frequently, providers and educators equating sex and gender together, which can lead to a lot of incorrect statements or can lead to harm.
My name is Kaiden, and I'm 26. I'm from a small town in Newfoundland, but as most queer people from the middle of nowhere, I now live in St. John's. I had an ultrasound scheduled, and when I walked into that room, which was in the part of the hospital where they do the mammograms, which makes sense, but you know, when you walk into a waiting room full of people who are there for very different reasons and they don't understand why you're there just based on looks, it's a little bit humiliating.
Kaiden is talking about being in a waiting room full of people who are waiting for a mammogram, although he was there for a different reason. But it got me thinking, what are the breast cancer screening guidelines for trans people in Canada?
My name's Dr. Sue Atkinson. I'm a family doctor. I work at Dalhousie Family Medicine and also the Halifax Sexual Health Centre, and I've been providing gender-affirming care for probably 30 years now. There are some guidelines based somewhat on cisgender guidelines because that's where most of the research has been done. There is reference to them in the Sherborne guidelines. The general thing is for trans feminine people that they would follow the guidelines as per cis women. They'd start their mammograms at 50 and could start them in their 40s. If they're on hormones, like if there's somebody who has purely had implants, never been on hormones, then probably it's not really needed. But if they're on hormones, you would screen them as per cis women, with the proviso of depending on when they started on those hormones. And I believe if they've been on hormones for 5 years, the highest recommendation for breast cancer screening starts at 50. But let's say someone didn't even start transitioning till they were 55, then you might not start their mammograms for 5 years. So you'd start them at 60.
For people who are assigned female at birth and have had top surgery, it's generally not recommended to have screening.
Yeah, and if the breast tissue has been removed, then the only thing I would recommend is just a self-observation.
Different amounts of tissue might be left behind for contouring or depending on the type of procedure that was done. But the guidelines are for anyone who's had top surgery is just generally not to do it, and also not to do anything like ultrasound or anything like that.
Yeah, right now I know in the Canadian guidelines there is not anything around doing ultrasound as screening for anybody. And you have to use some judgment. I have a personal friend who had top surgery, and because of their age and body habitus, the recommendation was to not do a full mastectomy because they were kind of round. And, if they were assigned male at birth, they would have a bit of a chest. And so the surgeon had recommended leave some tissue there so that it kind of goes with your body habitus. So, in that case, that individual probably should have mammograms
So we know how gender-affirming hormone therapy and surgery change screening recommendations, but how does breast cancer risk change surgical planning?
I'm Dr. Nadim Joukhadar. My pronouns are he, him, and I'm a plastic surgeon here in Halifax. I'm assistant professor at Dalhousie, and my focus is on gender-affirming top surgery. And I also have a special interest in medical education as well. We generally follow the guidelines suggesting that subtotal or total mastectomy leads to a very low cancer risk after surgery, but I never give firm numbers for that because, as you know, there's no great studies looking specifically at gender-affirming top surgery and cancer risk afterwards. Some might be in process right now, but of course it'll take a while to get that data. But we give them similar suggestions. So I usually tell my patients that you're going to have a significant reduction in your cancer risk, but you will still have breast tissue left behind, as it's not a oncologic resection. So with some breast tissue left behind, it can be similar to a cis male's breast cancer risk, but might not exactly be. And things to keep in mind afterwards are that you will still have breast tissue. So if you were to see a lump or a bump on your chest that was of concern, you'd get it checked out by your physician. There's just a chance that you might not have enough breast tissue to undergo a mammogram. And as a result, you would see your physician, likely get an ultrasound and biopsy would probably be where you'd start. And I also let patients know that if they come in with a strong family history of breast cancer and they don't have genetic testing or they don't have any testing to indicate if they do have a predisposition or not, I let them know that if you're going to proceed without getting those investigations done, as it can take years to get genetics done, for example, all those same factors apply. But if you have remaining breast tissue and you have a predisposition to breast cancer, of course, that could be of more concern to you. If we know someone has a predisposition to breast cancer, for example, if they're BRCA positive, then typically what we do is I'd consult with my general surgery colleagues, and they would either join for the case to ensure there was as close to a total mastectomy as possible, or they might just pop in at the end of the case and take a look. A lot of my colleagues, when I worked in Toronto, because it was similar to the weights for genetic testing, they basically gave me advice saying that you can just let the patients know that they will have breast tissue left behind and you have to continue some sort of screening possibly after if you have a genetic predisposition. So most patients honestly would proceed that way and didn't want to wait the number of years it would take for genetics, of course. But if you had a known predisposition, then we would involve that team earlier on. And I've had patients ask about their nipples as well. There's no studies, again, looking at specifically a gender-affirming surgery, but if you're getting like a double incision mastectomy with free nipple grafts, the nipple grafts are skin grafts. So essentially all that's left behind is skin. So I can't definitively say that you wouldn't have cancer risk increase from that, but I would imagine it'd be quite a low risk. And then even for like a keyhole or an inverted T, you're leaving a very thin pedicle tissue underneath the nipple. So it's not a lot of breast tissue that's left there, but there is some compared to a graft.
What about for a patient who's on estrogen therapy and is getting implants?
You'd still proceed with your cancer screening as you would typically. The only difference with implants is that there's special views, like an Eklund view it's called, under mammography. So you just want like a baseline mammogram after your surgery, after the initial healing period, just so you have that baseline for the secondary mammograms that you would get done, so they have it for comparison.
All right, let's talk about gynecologic cancers. In the cis population, estrogen that is unopposed by progesterone increases the risk of endometrial cancer. When you're taking testosterone, it is partially aromatized to estrogens, which would then be unopposed. But there's not actually any evidence that this does increase your risk of cancer. And if someone has average risk, oophorectomy and hysterectomy are not recommended solely for cancer prevention. So basically there's no recommendation for preventing these cancers because the risk from the testosterone that's aromatized to estrogen is hypothetical.
Right.
When it comes to cervical cancer, Nova Scotia and New Brunswick have very similar guidelines. They state that anyone who has a cervix who's had sexual contact should have regular pap tests when they are 25 and have them every 3 years, even if they're no longer sexually active. In Newfoundland, the age is 21. These are the current guidelines, but we do know that in Canada, we're switching to HPV testing instead of the cytology pap test. The procedure itself is very similar, so it would have similar barriers in that way for trans people. But if you get a negative test, there's a 5-year interval before you need to go in again. It's also just a better test. It will improve detection, but minimize unnecessary workup. That will become the standard of care in the Atlantic provinces soon. And PEI has already made the switch.
if you've had a hysterectomy, do you still need that cervical cancer screening?
They're not needed after a total hysterectomy, unless it was done for cancer-related reasons, then it might still be required. If you've had a subtotal hysterectomy, then yes, screening should be continued until around age 70. The exact age depends on the province. PEI ends the screening earliest at 66, but the other Atlantic provinces go an additional 3 or 4 years, and then you can stop once you've had adequate negative screening, which means that you've had a certain number of consecutive negative tests. There was a cross-sectional analysis done in 2019 by Kieran and colleagues that showed that trans and gender diverse people were less likely than cisgender people to have cervical cancer screening performed. Any guesses on the rates? For cis people, it's 72%.
Get screening?
Get screening.
I'm going to say 20% get
I
screening.
was going to say 30.
It's actually 56,
Okay.
It's better than I thought.
but still significantly lower than
Yeah.
the cis population. Barriers are at every level. Patient, the provider, the system. Any thoughts on potential barriers?
For some people, it could be like embarrassment / fear of, well, just acknowledging that body part exists on you kind of thing. But then also the fear of the healthcare system itself. You just want to avoid it at all costs. And so...
Yeah, I think also, just depending on what we already have, system-level barriers of access to care. If you don't have a primary care provider, if that's the type of thing that you would have to go through Maple or a clinic to do, now you have to explain your situation or out yourself to every provider. So it's kind of compounded by, like, if you don't have a family doctor that you can have a relationship with or that you're comfortable with, then it would make it extra difficult to get that care compared to a cis person who would already have a harder time.
Mm-hmm.
So my name's Xiaoqi. I use he, they pronouns. On a good day, some days I don't even know my own name and what I use. I've been a registered nurse for the last 10 years or so. It's been a very long time. And for the past 5, my specialty has been in the emergency department. I mostly work in Halifax, but I do a fair bit of traveling between here and British Columbia as well, where I work with smaller communities and populations. Going in for like a PAP is super uncomfortable, so that we generally choose somewhere that's safe. Shout out, obviously, to the Halifax Sexual Health Center. They're amazing. At this time and place, I don't think personally I would be comfortable going anywhere else for that. I have this fantastic new family doctor. She's wonderful, but I don't even know if I would go to her for that, just because based on the education and I don't want to say PR, but the PR that's given by the sexual health clinic, that is truly where I feel like people would judge me the least for going there. And I know for a fact that people don't feel safe coming into the emergency department for various reasons. There's no way in hell that somebody would choose to come to us for like their gendered health care, right?
I'm Pascale Joël. You can also call me PJ. It's shorter and easier to pronounce. I identify myself as a transmasculine, non-binary, gender fluid person, and I really don't care about my pronouns. My previous service provider did not know anything about the transgender world at all. So it was very unaffirming when I was going for a PAP test. It's not something that's fun to begin with, but the environment is very feminine, and we don't necessarily take into account that some non-binary and men or other gender-identifying folks require that same care. And now I'm due, and I'm like, ugh, I don't know if I want to go, but I changed service provider since then, and it's not necessarily night and day, but dawn and dusk maybe between the two. And if I can speak for a larger pool of people, going to the gynecologist is hard when you are not strongly identifying with your bottom part.
We can see how important it is for patients to feel comfortable accessing this type of care, and that involves showing that you can provide affirming and informed care. Another barrier is awareness that a patient needs this screening. For a long time, raising awareness about cervical cancer screening was targeted exclusively at women. Not thinking that it applies to them, a trans man might not recognize it's not about gender, but anatomy. And this also happens to providers as well.
Sometimes it happens to me. I'll have someone who I've taken care of for years, and you kind of forget that they have a cervix. And then all of a sudden I'll be like, wait a second, when was the last time we did a pap smear? So it is easy to forget, particularly as someone has, if they're transitioning with surgery and hormones. But sometimes it comes also of not recognizing that depending on what body parts you have, I always say if you've got the bits, you got to take care of them. So yes, people do forget or people just don't know.
Another thing is that people who are taking testosterone might experience more pain or discomfort during or after the procedure because there could be testosterone-induced vaginal atrophy. However, if you are performing a pelvic exam and you see erythema, you have to remember not to assume that it's due to atrophic changes. You should still investigate all the usual causes of inflammation.
Is there anything you can do to make that experience better? Are there any techniques?
Sometimes if you're needing to do a bimanual, I try with one finger because sometimes 2 fingers is too much. I will often use a pediatric speculum. Sometimes if people are having a lot of troubles, either with pelvic exams or pap smears, or if they're having troubles sexually, then using a low dose of estradiol is actually helpful if it's really necessary. For physical exam, unless somebody really wanted it, I wouldn't necessarily say, hey, we're going to do your PAP in a year, let's put you on this to make it a little easier. I'd be more likely to go with smaller instruments. But if there was someone who needed frequent exams for some reason, or used their vagina as part of their sexual activity, then using something like a estrogen. And luckily, the nice thing about those low dose vaginal estrogen things is that they hardly raise your serum estrogen level at all, to the point that you don't have to use uterine protection with progesterone. So they're safe to use in that respect.
How can providers take steps to overcome these barriers with their trans patients?
Ask what terms they want to use for anatomy, ask what they're comfortable with, make sure that you bring it up, bring up the uncomfortable conversation, be the one to do that, because that's easier for you than for them.
Another thing that providers can do is they can offer accommodations, like having a support person in the room, or giving someone anxiolytics before the PAP test.
When it comes to things like health initiatives or health education material that's typically displayed in clinics and offices, that could be more inclusive.
For sure. Hopefully having an affirming provider can make this type of care tolerable for patients. However, what happens when your circle of care needs to expand beyond the primary care providers that you've built a relationship with?
My name is James Moriarty. I'm from Newfoundland, and I've been a survivor of stage 4 endometrial cancer for 4 years now. And it's been a ride having a gendered cancer as a trans person.
Can you walk us through what led to that diagnosis?
It kind of started a year or a little more before I was actually diagnosed. I started having cramping and bleeding and stuff like that, and I just kind of figured it was because I've never been particularly diligent with my testosterone shot, so I just was kind of assuming that my ovaries and my uterus were waking up again and being like, hello, we're here, we do stuff. So I didn't think a whole lot about it, but I did mention it to my doctor. She scheduled me for ultrasound, and I didn't go to the appointment because I didn't want to end up having some kind of extended relationship with women's health. Joke's on me. So yeah, I didn't address it for another year and a half. The cramping and the pain started getting pretty bad to the point where I actually stopped taking testosterone because I thought maybe my body would reset itself naturally, and that's all that needed to happen. I would go to the bathroom and it would make me bleed and throw up. So eventually I did go to my doctor about it again, and she was like, you really do have to get that ultrasound now. And so I did. And then a week after the ultrasound was an MRI. A week after the MRI was a CT. And a week after the CT was a hysterectomy. It happened all really, really quickly.
What was it like navigating those very gendered spaces?
I definitely experienced some barriers just from not wanting to be associated with these healthcare spaces. I had that appointment for that ultrasound, and it was scheduled at the Children's Hospital because it was a transvaginal ultrasound, and that's where they have that machine. So I called to confirm my appointment, and the person who picked up the phone said, you don't have an appointment here. This is for women. And I was like, okay, that's interesting. I have a piece of paper here that says that I have an appointment here. Could you just maybe check with your eyeballs? She's like, no, it's for women and pregnant women. Okay, thank you so much for telling me. I really appreciate that disclosure. Please, can you just check your appointment book? None of this exchange needed to happen. You could have just said, I'll check, and then we would have been off the phone already, but now I'm annoyed and I'm experiencing a microaggression. Great. My oncologist was a nice person, though. She did a lot of research before I got in contact with her, both in terms of how to, talk about me and talk to me and address me properly, but also in terms of trying to find more information about gynecological cancers in trans people who have been on exogenous hormones and stuff like that. So that was nice. It was nice to know that she had put that effort in, even if there wasn't a lot of studies or anything for her to actually look at. But the fact that she put that effort in was meaningful to me.
For trans and gender diverse people, their relationship with their body can be somewhat complicated. For anyone of any gender, cancer can have a huge impact on that relationship.
I mean, I definitely went through some periods of feeling not grounded or not rooted, or not as grounded or as rooted as I was before. The fact that I had to have a hysterectomy was also something that was, it affected me a lot, because something that I've always wanted to do is to have a child. And so being forced into a place where I can no longer make that decision is, it takes away a piece of agency from me. And in any context, not having agency over your body is like, it sucks. But especially for somebody who's trans, not having agency over your body can be a lot more traumatic, even if that agency is to keep an organ that might not be traditionally associated with the gender you're presenting as. Like, a lot of the comfort in my gender came from being able to envision myself as a seahorse puppet. I can't do that anymore. Things are different now.
Do you feel like you were able to have the same conversations and the same options surrounding things like fertility that would be offered to a cis woman?
Luckily, my oncologist is awesome. So she just basically asked me, do you want to do any fertility preservation? It was at the point where we had to cut pretty immediately. So there was no real time to be like, okay, well, let's just wait and we'll do some egg harvesting. But we did have a conversation about one of my ovaries, because one ovary was completely engulfed in tumor, and the other one from the scans looked totally fine. And so she said that if, when she went in, it still looked fine and there was no involvement, that she would just leave the ovary there, so that if I wanted to in the future, that I could pursue having biological kids, which is very nice of her, and I really appreciate that she did that. And I think sometimes, for certain reasons, things are missed when you have that big appointment where you get your diagnosis and they give you the 10,000 trees worth of paperwork and all of that. But sex was something that wasn't covered for some reason. I had to call my oncologist's office and be like, hey, this is a really weird and personal question, but can you ask the doctor if it's okay for me to masturbate yet? And nobody ever went through things like physically when I would be recovered, or chemo. They didn't go through any of the sexual side effects or concerns that might have presented. And I don't know if it was because I was single at the time or not, but it is something that I found strange. Do you know what I mean? Even when my mom had her hysterectomy, I remember the nurse saying to her in front of me that she wouldn't be able to have sex for X amount of time. But nobody ever had a conversation like that with me when I had my hysterectomy.
James' experience navigating his cancer care reflects a lot of what we see in the literature. Trans and gender diverse people avoid care out of fear of medical transphobia or discomfort with gendered healthcare. Negative and positive experiences shape how someone thinks about healthcare and their willingness to access it. It's important not to assume how someone feels about their anatomy, even if it's incongruent with their identity. It's not uncommon for the topic of sex to be avoided by providers, especially in the context of trans patients. I talk a little bit more about this in another episode where we look at the intersection of disability and gender diversity. So if you're interested in that topic, you can check out that episode. We've talked a lot about breast cancer and gynecologic cancers, so let's move on to the topic of prostate cancer. To minimize complications, prostatectomies are not done as part of gender-affirming bottom surgery. But the removal of the gonads and the use of estrogen therapy probably does reduce the risk of prostate cancer and BPH. It seems like most of the cases of prostate cancer that happen in people who are taking estrogen therapy, it happens when they started the therapy after the age of 50. And it's thought that they probably had occult neoplasm before even starting the hormone therapy. However, it is recommended, even if someone has started the hormones earlier than that, it's still recommended to follow the same guideline for anyone with a prostate.
How would estrogen affect your PSA levels?
So that's a really good point. The recommendations are to use the same PSA screening test, but yeah, you'd have to be aware that the upper limit of normal might have to be reduced for someone who's taking estrogen. There was a paper in 2015 by Trum and colleagues, and they suggested using 1.0 nanograms per milliliter as the upper limit of normal.
So being in an estrogen hormonal milieu might reduce your risk of prostate cancer. Does it do the same with testicular cancer?
Androgen suppression might reduce your risk of testicular cancer, but again, there's no specific guidelines for trans people. Testicular cancer screening is not routine for anyone, so it's not recommended in this population either.
But you could always do a self-exam.
Good point. Yeah, and if you have a patient who's on estrogen and androgen suppression, and they still have a persistent elevation of testosterone, that's when you would start looking for a testicular tumor. On the topic of testicles, scrotal pain is not uncommon in the trans and gender diverse population.
Could that be related to practices like tucking that a lot of trans femme individuals might engage with?
Yeah, tucking is a common cause of scrotal pain, and it can also cause symptoms of prostatism or infections like epididymoorchitis, prostatitis, or cystitis. Another thing, it's not really understood how it works, but starting hormone therapy can actually cause scrotal pain. Mm-hmm. Generally, it's benign and improves spontaneously, and you just kind of have to reassure people that it will go away. I mean, of course, if someone started hormones, you can't just assume that that's the cause, and you have to rule out everything else that it could be. But it is important to educate patients on how to tuck safely. We can make assumptions looking at data from cis people, but we don't have a lot of data for trans people, specifically on all of these different pathologies that we've been talking about. But we do know that trans people experience all of the same common maladies that the rest of the population experiences, regardless of hormone status.
My name is Eleanor. I am 24 years old. I'm a trans woman, pronouns she, her. I have been on feminizing hormone therapy for a bit over 5 years at this point. I had an inguinal hernia. I was a year on HRT, and that was kind of an awkward situation for me to be in because I wasn't actually out a lot of places yet, and it was very gendered, and I think that kind of kept me in the closet with my providers. So I kind of just dissociated and boy moded through the whole thing because I guess the gendered aspect of it bothered me. I was like, oh, here I am trying to present myself as a woman, getting a procedure almost always done on men because of, anatomy. And that was awkward. But people did try to be delicate about it, but I think I was too in my head to really appreciate that. They asked me what medications I was on. I told them I'm on estradiol, spironolactone, et cetera. But when they were like, well, why are you taking estrogen? I was just like, personal reasons. They just left it at that. They didn't prod. I think someone at the hospital asked if I used a different name. I just said no because I didn't want to bother. Honestly, I don't know what more could have been done. I think that was just kind of a fundamental problem with dysphoria. I was grateful that there wasn't prodding into the matter. It was, professional. I think that helped for the approach I was taking because, they gently offered. I wasn't ready for that. So I wasn't treated any differently or anything like that.
Even if we create welcoming, inclusive spaces, there may still be other factors that make this type of healthcare challenging, including dysphoria. Another area of healthcare that is highly gendered is pelvic physio.
My name's Amy Prescott. My pronouns are she, ze. I am genderqueer. And as a physiotherapist, I do orthopedic and pelvic health. I also have a special interest in gender-affirming care and pain science. In pelvic health, we do a lot of incontinence, whether it's stress urinary incontinence, urge urinary incontinence, or mixed urinary incontinence. We treat pelvic pain, whether that's pain with sex, pain with day-to-day living, pain with tampon insertion. Sometimes it's just skin. We kind of assess that aspect of pain. And then also kind of underneath that, often is tied in with things, but sometimes just happens by itself. Pelvic organ prolapse in varying capacities, as well as we do a lot of pregnancy assessments. So it's kind of like those areas. Pelvic health physiotherapy is amazing, and you can really have such an influence on somebody's quality of life. But I think as pelvic floor physios, we've really done a disservice to our profession when we pigeonhole ourselves and really label ourselves as women's health. If 1 in 5 people have a pelvic condition, which we expect that number is underreported because we're not getting the true representation of people who are assigned male at birth, just in general, like, why is it women's health? A lot of these women's health centers are the places that have been really progressive and really champion the progression in care that we see moving forward. So not to discredit these places either. Absolutely, we need more healthcare focused on pregnancy and pregnancy care. Still an underserved population within healthcare settings, but we can expand it so much more broadly. And there's so many populations that can benefit from pelvic floor physiotherapy that don't feel represented in the care that's being offered that we can provide care for. Within a gender-affirming care context, I'm thinking a lot about somebody who's going in for surgery, pre-op rehab, getting them to be as prepared for surgery as much as possible, but also post-op and managing certain things. I think a lot about swelling, whether it's from a surgery, whether it's from a procedure, but then related to that is pain and how pain really presents within queer and trans populations. Because we do see higher rates of chronic pain. We do see higher rates of pelvic pain. Specifically, we see higher rates of chronic pain in trans masc populations. And there's not a lot of research in this field. Pelvic pain often is really connected into the nervous system, or it can be connected into our nervous system, which can be affected by that allostatic load, by chronic stressors that we don't have time to recover from. So I see a lot of pelvic pain.
Are there barriers that trans and gender diverse people face when accessing physio?
I think the biggest barrier is the cost. A lot of queer and trans people do not have benefits, unfortunately, because we tend to exist in these careers that don't necessarily have benefits or coverage. That education piece too, so that the public knows in general that physio can help with this. That's a huge barrier. And then also just having that knowledge be integrated within physiotherapy training.
Healthcare can be scary in general, and for trans and gender diverse people, areas of healthcare that are gendered can add an additional burden.
Yeah, actually, I'd like to share a recent experience I had in the obstetrics and gynecology clinic as a clerk. There was a man who walked into the office who, said he was lost. He was looking for the gen surg clinic, and the staff joked about it, saying things like they wouldn't know what to do with him and they don't deal with those parts. This stuff wasn't said with bad intent. And I want to be clear, these people I know, they are very kind, they're competent, they're well-meaning individuals, but it made me think about the trans masc folks who access obs-gyn care. And, I also recognize that this space is historically been centered around women, and for many patients that focus feels affirming, it feels important. At the same time, when discomfort and assumptions or transphobia show up in these spaces, even in subtle ways, people can delay seeking care, and we know that delaying care can lead to worse and sometimes devastating health outcomes.
And although it's an oversimplification to say this is an area where an individual can make a difference.
Yeah, this is something we can do stuff about. Obviously we live in a place where, there's family physician shortages, etc., but this is something you can control. You can be inclusive, you can put up a poster, you can remind staff not to make assumptions, or do your best to know which of your patients might need that extra consideration.
And that won't solve every problem, but it is a start, and it's doable.
It's good to know if a staff member is going to treat you respectfully or not, especially in times of uncertainty and fear, which is often what those times are when you're talking about being involved with healthcare. Most people don't access healthcare because they're feeling well. They're accessing healthcare because they're not feeling well, and that can be scary and feel really vulnerable.
It's nice to know that your healthcare provider cares, that they're sympathetic or empathetic with you no matter what. I guess that's what I most appreciate to see in healthcare settings, is just understanding.
Thanks for listening to this episode of Gender Queries, and thank you to our guests for sharing their stories and expertise. Check out the show notes for transcripts, sources, and resources recommended by our guests. You can contact us at genderqueriespod@gmail.com or find us on Instagram at genderqueriespod.